Okay. All right. So thank you everyone for tuning in again to our Empire series. We are very fortunate to have Dr. Mehrazin with us today. Um, before we begin, I just wanted to remind everyone that we do have a YouTube page up for anyone who missed lectures, for anyone who wants to go back and study or review the lectures. They're available on the Empire Urology YouTube channel. The whole compilation is there. Dr. Ankil Sanji at New York Medical College was so gracious in helping us put that together. So I wanted to give him a shout out. So please, if you have a moment, go see all the lectures that we've had over the past few weeks, and we'll continue putting the lectures from this week and on that YouTube channel within a day or two. Just to Dr. Mehrazin, just before we begin, I'd like to introduce you, but I'd also like to we've kind of been gauging our speakers in regards to some mentoring advice,
Right.
kind of where they came from, why they chose their field. So, if you don't mind, Dr. Mehrazin is coming to us from, he completed his residency at, and correct me if I'm wrong, it was University of
Yeah.
Tennessee, fellowship at Fox Chase, and now you're, assistant professor of urology at Mount Sinai in New York City. What drove you to urologic oncology, and
Um,
especially with the interest in kind of
right.
uh,
So going a little bit further back, I went to med school to become a neurosurgeon. My dad is a neurosurgeon. I was exposed to only neurosurgery. I mean, this is all I wanted to do. And it was like a fourth year July. I mean, fourth year medical school. I mean, I had my sub-I rotations all set up, and we were just doing that filler 1 week gap for urology rotation. It was Monday morning. I went in the OR. I was an attending with two residents. They were blasting a stone. They were having a great time. I mean, they were just, the environment was like I've never seen before in an OR, especially in surgery. The next case was TURBT, and then I remember inguinal orchiectomy, and then open partial. I mean, that was one day I was like impressed with technology, how much they covered from the stone to the bladder tumor, orchiectomy, and then the kidney mass in one day.
sure.
And um, also they had just immediate gratification. I mean, the stone was out, the tumor of the bladder was resected, the or testis tumor was out. I mean, it was just, usually you don't really see that in the surgical field. So the whole week was just like impressive for me. And that weekend, I basically made up my mind that maybe I should do urology. And I remember that I sat out, I didn't match that year. I just went for urology research 1 year. I published some papers with my mentor, who's still a very good friend of mine,
Mhm.
and I got into urology residency. Halfway through, I was at PGY3. Then I saw myself being more interested into more of a complicated or open cases. Like I remember I was in PEDS. The Mitrofanov cases was impressive. I really enjoyed doing those diversions. And then cystectomy, RPLND. So that was, I figured in order for me to continue, I guess, research and also be able to do these big cases is for me to do a oncology fellowship.
Mhm.
I applied for five fellowship positions, and I interviewed the five, and I went for my first choice, which was Fox Chase. And um, second year fellow over there, we were doing research, and I started looking for jobs. I obviously wanted to continue to do academics. I wanted to produce papers, and I so mentor residents, and also be able to do these big cases. And you can typically do these cases at academic major centers who can support the patient post-operatively.
Mhm.
Um, and I started interviewing at cities that I felt like I have a reason to be at. My sister's been in New York for all these years, and I never thought I would end up in New York. And
Yeah.
just things work out because they always do. And I ended up coming to Mount Sinai Hospital.
Yeah.
And August is going to be 6 years here.
Wow.
Um,
Yeah. It's amazing to kind of hear how people especially where you go to medical school in one state and you do training in another, and how you end up in one place. I find it fascinating that
Right.
people are able to experience different training styles across the country and kind of incorporate a little bit of everything now into their own practice. And there are other people. I think Dr. Stifelman, who's next, he's been mainly a New Yorker,
Right.
and you know, people do it differently. But and a lot of people at Columbia are very similar like that. But I think it's fascinating to see people kind of grow and
Right.
come from different areas. But well, thank you. I won't keep you longer. It's a perfect segue into your talk. We'll be talking about testicular cancer, diagnosis and treatment of early stage testicular cancer, focusing on the AUA guidelines. And again, I'll give it to you. Thank you for joining us.
Thank you. All right, so I picked this topic because as a resident, testis cancer always seemed to be a little bit complicated, the staging and then the treatment algorithm that you have to go through. And, instead of, I know you have had a couple of good talks and about testis cancer, but I picked the guidelines because it's important to know. It's there for us to know it, especially for graduating chiefs who are going to be taking their written boards and then oral boards. I mean, you need to know all the guidelines. They will ask you questions. They're not hard to read. Their PDFs are online. And it's good for you to be familiar with these because this is where the test questions come from. So I wanted to basically summarize and go through the guideline one by one. So hopefully this will be a good review. And if you need to access these, you can either go through my talk again, or you can just go on the website, AUA website. So I have no disclosures. Again, this is based on guidelines. These authors spend a lot of time putting this together. So as urologists, take your, spend some time reading them and get familiar with these guidelines. So we'll start with some epidemiology. Testis cancer is most common solid malignancy in young men, usually 20 to 40 years of age. 6% of cases occur in children and teenagers. 8% occur in men over age of 55. American Cancer Society estimates that for 2020 in the United States, there will be about 9,600 new cases and about 440 deaths. And the incidence of developing testis cancer is about 1 out of 250 male will get it throughout their lifetime. So those are some epidemiology that you should know. Risk factors on descendant testicle, 4 to 6 times increases your chance of getting testis cancer. And when you have or someone undergoes orchiectomy, the risk factor is still there, but it basically drops by 50%. If you have a personal history, for example, 12-fold increased risk of developing germ cell tumor in the contralateral testis. So if you have a testis cancer, then you are typically at a higher risk of developing it in the contralateral compared to average population. Family history, there are some reports that HIV infection, especially those with AIDS, these patients develop testis tumor. Of course, carcinoma in situ. And then it's known that Caucasians are more at risk compared to African American or Asians. There's a report on body size. I mean, I cannot validate this. I don't think there's really a correlation, but it has been listed, especially if you go to American Cancer Society website, it is reported there. There's no way to prevent it. The WHO 2016 classification for post-pubertal germ cell tumor. Germ cell tumors are broadly classified as either germ cell derived tumor or non-germ cell derived tumor. Okay, so compared to non-seminomas, pure seminomas tend to develop at a later age, are of a lower stage at diagnosis, and grow at a slower rate. The risk of occult disease for stage 1 disease is lower for seminoma compared to non-seminoma. So overall, it has better prognosis. And lastly, keep in mind that pure seminomas are even more highly sensitive to chemo relative to non-seminoma, and sensitive to radiotherapy, which is not the case for non-seminoma. Staging, prognosis and initial management decisions are basically dictated by the clinical stage. And you do that by doing a orchiectomy pathology, and then you have the post-orchiectomy markers and imaging. So that's how you stage. I think that most of the challenge to remember staging of testis cancer comes here. Like, I mean, it's a little bit more involved compared to other GU cancers that we see. To try to simplify it, I mean, obviously TX, T0, TIS is easy to remember. T1 is the testis tumor is confined within the testis, but there's no lymphovascular invasion. So you remember that. If you see lymphovascular invasion, you already go into T2. So no lymphovascular invasion, and then remember 3 centimeter cutoff. If the tumor is smaller than 3 centimeter, it's T1A, and if it goes more than 3 centimeter, then you have a T1B. Again, if you have lymphovascular invasion, you're already looking at T2 and involvement of the tunical albuginea. Okay, T3 is when the tumor gets into spermatocord above the testis, and then T4 is when the testis tumor is invading the scrotum. I have personally not seen it, but obviously it's there, and it's for basically getting to different prognosis there. Nodal staging, remember the 2 centimeter and then 5 centimeter. So if it's 2 centimeter lymph node in retroperitoneum or smaller, you're looking at N1. N3 is more than 5 centimeter, and N2 is between those two. So anything between 2 and 5 centimeter, you're looking at N2. For metastasis, M1A is involvement of non-retroperitoneal lymph nodes, such as pelvic lymph nodes or inguinal lymph nodes, and pulmonary metastasis. Anything outside of that, if you have mets to the non-pulmonary visceral mets, such as liver, which is most commonly seen, or other sites, then you're looking at M1B. For the S, for the markers, this is, again, not too hard to remember. Just remember the 1.5 time or less for LDH and less than 5,000 for HCG, and AFP less than 1,000. And if it goes over 50,000 for beta HCG and more than AFP, more than 10,000, then you're looking at S3. So anything between would be S2. So lymph nodes, 2 centimeter and 5 centimeter. Remember that for N1 and N3, anything between is N2. For metastasis, if you have pulmonary mets and non-retroperitoneal lymph nodes, you're looking at M1A. Anything other than that, anything else would be M1B. And the markers, just remember those numbers: 5,000, 50,000, 1,000, and 10,000. And that will put you, that will basically make it easier for you to come up with the S designation. So AJCC prognostic stage group. So remember, stage 1 is confined to the testis. There's no lymph node involvement. When you have lymph nodes, you are looking at clinical stage 2. And when you start to see mets, you're looking at stage 3. So now that I went through some background, we're gonna go over the guideline statements that have been issued. These guidelines are important, again, to know, to memorize, again, for your in-service and for your oral boards, okay? So a solid mass, statement 1, a solid mass in the testis identified by exam or imaging should be managed as malignant neoplasm until proven otherwise. It's a clinical principle. In a man with a solid mass in a testis suspicious for malignant neoplasm, tumor markers such as AFP, ACG, and LDH should be drawn and measured prior to any treatment, including orchiectomy. Remember, seminomas do not produce AFP. Elevated AFP and rising AFP in a patient with quote-unquote pure seminoma, it's not seminoma. I remember this was my oral board question. If you have a pathology or orchiectomy specimen that comes back as seminoma and you had an elevated AFP, you just need to call your pathologist and say, look at the specimen again. I mean, that's, it just doesn't, you cannot see AFP with non-seminomas. Prior to any definitive management, patients should be counseled about the risk of hypogonadism, which I will go through the numbers later on, and infertility, and should be offered sperm banking when appropriate. In patients without a normal contralateral testis or with known subfertility, this should be considered prior to orchiectomy. Not necessarily these patients need to do a sperm banking prior to orchiectomy. It's usually preserved for when you want to put them through chemo or radiation. So, but again, if you have a contralateral testis that is atrophied, then you need to offer sperm banking to these patients. Up to 50% of men have impaired semen parameters and 10% are azoospermic. At the time of diagnosis, you will see that. I've had patients that prior to orchiectomy or right after orchiectomy, we did sperm banking and they had 1 or 2 viable sperms only. So you do see that. Following chemotherapy, all patients will become azoospermic with recovery of spermatogenic function in 50% and 80% within 2 and 5 years respectively. In regards to radiation, it's a return to pre-irradiation sperm concentration may take 9 to 18 months. With 1 gray, it's basically radiation dose dependent. It can take up to 30 months if you do 2 to 3 gray radiation, and maybe more than 5 years when you're delivering more than 4 gray of radiation. So if you do more than 4 gray, there is a possibility that there's a permanent azoospermia in these patients. So scrotal ultrasound with a Doppler should be obtained in patients with unilateral or bilateral scrotal mass suspicious for neoplasm. I mean, we all know that. On ultrasound, seminomas tend to look more hypoechoic and homogeneous. Non-seminoma are more heterogeneous with irregular margins. You can see some calcification. Excuse me. Cystic area and hemorrhage. And then you can, burnout tumors are the ones that you have a normal exam. Maybe you see a little bit of calcification on within the testis. These are in those patients that they present with elevated markers, and on the scan they have retroperitoneal lymph nodes, but then the ultrasound is typically normal. So those are basically considered burnout primary tumors. Testicular microlithiasis, in the absence of solid mass and risk factors for developing germinal tumor, does not confer an increased risk of malignant neoplasm. Before, this was not the case. They were saying if someone has microlithiasis, you need to get ultrasounds annually, at least follow them, but that's not the case. Meta-analysis shows no risk factors. I mean, the meta-analysis shows that this is not a risk factor for developing testis tumor. Patients with normal serum markers and indeterminate findings on exam or ultrasound should undergo repeat imaging in 6 to 8 weeks. MRI should not be used in the initial evaluation and diagnosis of testicular lesions. You do see it sometimes when we get referrals. The referring urologists have done an MRI as well. That's not necessary at all. So orchiectomy, patient with testicular lesions suspicious for malignant neoplasm and contralateral testis should have a radical inguinal orchiectomy. Testis sparing is not recommended, which we'll get into in a bit, and transscrotal orchiectomy is obviously discouraged. The prostheses talk, I mean, we always have to offer this to patients, and we always do, but I can tell you I have never put one in, and a lot of patients, for some reason, they never come back for it. I mean, it's never a concern, at least in my opinion, but the guideline expert opinion says that it should be offered, and it makes sense. We should offer it to the patient prior to orchiectomy, so if they need it, we can potentially put one in at the time of orchiectomy. Patients who have undergone scrotal orchiectomy for malignant neoplasm should be counseled regarding the risk of obviously recurrence and may rarely be considered for adjuvant therapy. This, again, was not the case. I remember as a resident, I have an in-service question. The answer was basically do adjuvant radiation or excise the scar from the scrotum to minimize the risk of recurrence. Meta-analysis from Johns Hopkins showed that only 2.5% of these patients have recurrence, and 9% have viable germ cell tumor after excision. So we don't really need to do that. We just have to follow them. If there's any concern later on, it can be excised or radiated. So keep that in mind. But again, obviously, scrotal orchiectomy is not recommended. In regards to testis sparing surgery, it's again done through the inguinal incision. It may be offered as an alternative to radical inguinal orchiectomy in highly selected patients who are wishing to preserve gonadal function. If you're thinking about doing testis sparing surgery, I mean, you got to tell the patient that there's obviously high risk of recurrence. They need to get serial exams and ultrasounds. You need to discuss potential need for going back to complete the orchiectomy or do a radiation. And at the same time, they need to know if you end up doing a radiation, then you're going to be affecting the spermatogenesis and testosterone production anyways. And obviously, there's a risk of testicular atrophy when you manipulate and resect part of the testicle. And again, that will cause infertility and subfertility. When testis sparing surgery is performed, in addition to the suspicious mass, multiple biopsies of the ipsilateral testicle of the normal parenchyma should be obtained for evaluation by experienced genitourinary pathologist. Last week, I had a 29-year-old patient who was referred to me for orchiectomy. He had a complex cystic lesion in the lower aspect of the testicle, consistent with neoplasm. And it was 1.8 centimeter. We ended up the day before, I made sure my GU pathologist is around. We delivered a testicle through inguinal incision, and it opened a tunica albuginea. The mass was resected. We sent it to the pathologist. It was reported as a benign cystic lesion, and we delivered a testicle, did an orchiopexy. Again, it is in a few select cases, it is doable, and we can offer that to select patients. And in the next slide, I'll go through some data as well. In patients with malignant neoplasm after testis sparing surgery, clinicians should inform patients of the risk and benefit of surveillance, radiation, orchiectomy, which we already talked about. If you end up doing a radiotherapy, you want to do 2 gray for 9 to 10 daily sessions. 12 of 20 gray radiation should do the job. And also, if the clinician should inform the patients with a history of germ cell tumor, again, the risk of second primary tumor in the contralateral testis, and lifetime risk about 2%. Testis sparing surgery is considered when we think that it's going to be a benign testis tumor. These are usually less than 2 centimeters in size. That's just last month in the White Journal, there was a multi-center study out of Italy looking at testis sparing surgery, and among 147 patients who had normal testis marker with a solitary lesion of less than 2 centimeters in size, neoplasm was only reported by 14%. So in select patients, again, it's this is a viable option. When it comes down to staging, as I mentioned earlier, I mean, it's orchiectomy, and then you do markers, and then you do imaging. In regards to markers, nadir serum tumor markers should be repeated at appropriate half-life intervals after orchiectomy for staging and risk stratification. AFP is a protein secreted by fetal yolk sac and also liver and GI tract. Half-life is about 5 to 7 days. And for HCG is a glycoprotein that is produced by placenta to maintain corpus luteum during pregnancy. So HCG can be elevated in a number of other malignancies, such as, the liver, and you can see in lung cancer and pancreatic cancer. In germ cell tumors of the testis, including both seminomas and non-seminomas, the cancer cells can transform into syncytial trophoblasts, and that secretes the HCG. The half-life for it is about 24 to 36 hours. And levels of ACG more than 5,000 or S2 are usually indicative of a non-seminoma, and higher levels of ACG are associated with worse prognosis. Keep in mind, you will see in about 15% of seminomas elevated ACG, and it has the same prognosis as seminomas that does not produce ACG. And then lastly, 8-LDH is a cellular enzyme found in every tissue in the body and is expressed on chromosome 12p, if you really have to know that. I don't know if they will ask you that question, but the half-life for that is about 24 hours. For patients with elevated AFP and ACG post-orchiectomy, again, you should monitor the serum tumor markers with appropriate half-life to give it enough time for them to nadir or normalize before you pull the trigger on treatment. So for patients with metastatic germ cell tumor, mostly stage 2C or 3, requiring chemotherapy, clinicians must base chemotherapy regimen and number of cycles on International Germ Cell Cancer Collaborative Group risk stratification. The chemotherapy regimen usually is a BEP, bleomycin, etoposide, or cisplatin, or etoposide or cisplatin. For good prognosis, non-seminomas, you do EP times 4 or BEP times 3. It's basically dealer's choice. There's really no data that supports which one is superior over the other one. But you got to keep in mind, if there's a patient with restrictive lung disease or history of asthma, you want to avoid giving bleomycin. In intermediate or poor risk factors, again, BEP times 4 is given, and then, or you can give EP and IFO. And keep in mind, in seminomas, there is no poor risk prognosis. So for patients in whom serum tumor markers levels are borderline, elevated post-orchiectomy, again, the trend should be confirmed before management decisions are made, as false positive elevations may occur. So next thing in appropriate staging would be imaging. In patients with newly diagnosed germ cell tumor, you should obtain a CT of abdomen and pelvis with contrast. There's no need for MRI unless CT is contraindicated. Maybe a patient is allergic to iodine contrast, or they have a poor renal function that they can't handle the contrast given by CT. Then you do an MRI. Otherwise, CT has adequate sensitivity, and the specificity is reported that accuracy of the CT for diagnosing retroperitoneal lymph nodes is about 83%. In the presence of elevated and rising post-orchiectomy markers or evidence of metastasis on abdominal or pelvic imaging, that's when you pull the trigger to get a CT of the chest. I mean, otherwise it's not indicated. If you don't have any intra-abdominal pathology, or if you have a chest X-ray that is normal, then there's no need really to get a CT of the chest. Especially in seminomas, really, again, as I said, if the intra-abdominal abdominal CT is normal, then you can completely omit getting a thoracic or chest imaging. There's no role for PET scan at the initial diagnosis of germ cell tumor. They can be done after patients have gone through chemotherapy for seminomas, but initially there's no role for that. Principles of management. Management decisions should be based on imaging obtained within preceding 4 weeks and serum tumor markers within preceding 10 days. So this basically what it means is there is a rapid doubling time of many germ cell tumors, particularly non-seminoma germ cell tumors. There's a risk of disease progression between staging studies and intervention. So you don't want to have too much of a lag from your last scan and your last tumor markers. If you're going to do surgery or you want to put a patient through chemo, you want to do so in a short window. Otherwise, if your staging or your treatment could be either you're going to be over treating or under treating someone. So keep that in mind um, uh, when you treat a patient for testis cancer and they had a previous elevated tumor markers. Management decisions should be made in a multidisciplinary setting that involves GU oncologists, medical oncologists, radiation oncologists, pathologists, and radiologists. I put that in because there's a report. There are reports that when these orchiectomy specimens are read again by GU pathologists, these histology can be changed. I think there was a report that 7-8% of the uh, seminomas were converted to non-seminomas, and lymphovascular invasion was altered 20% of the time. And you got to keep in mind, again, if there's a presence of lymphovascular invasion, it's not a T1 anymore. You're looking at a T2. So as a result, your treatment paradigm changes. In patients with normal serum tumor markers and equivocal imaging findings for metastasis, clinician may consider repeat imaging in 6 to 8 weeks to clarify the extent of disease prior to making a treatment recommendation. So again, if you're not sure if you have a lymph node in the retroperitoneum or if they're enlarging, just give it some time, 6 to 8 weeks, nothing happens, and you can just re-image them and then go from there. Seminomas, you should know that surveillance after orchiectomy for patient with stage 1 seminoma is highly recommended. For stage 1 seminoma surveillance, adjuvant carboplatin and adjuvant radiation therapy are all options. More than 80% of the patients will not experience recurrence. Surveillance associated with the lower risk of short-term and long-term treatment-related morbidity, such as secondary malignancies that you can get with radiotherapy or chemotherapy. Adjuvant carbo or radiation reduce the risk of relapse down to 3 to 9% from 20%, but you got to keep in mind that it does not improve cancer-specific survival compared to surveillance. Basically, your specific survival your cancer-specific survival is still 98%. So if that means if even you watch these patients and at some point you see enlargement of lymph nodes in the retroperitoneum, you can still pull the trigger and do your treatment with chemo or radiation, and you still haven't lost time and you haven't really jeopardized the patient's ultimate outcome. So recommendation is typically surveillance. For patients with stage 2A or 2B seminomas with lymph nodes less than 3 centimeter, clinicians should recommend radiotherapy or multi-agent cisplatin-based chemotherapy. For stage 2B seminomas with lymph nodes more than 3 centimeter, chemotherapy is recommended. That's basically, it's these are the patients that you should not do surveillance because there is most likely cancer or neoplasm within retroperitoneum. Radiation therapy and multi-agent chemotherapy both result in good results, more than 97% survival. Radiotherapy, you do a dog-leg field up to 30 gray, and chemo is either, as I said, 3 cycles of VEP or 4 cycles of EP. Again, surveillance is not recommended here. For stage 2B seminomas, there are fewer relapses after chemotherapy compared to radiotherapy, and the RPLND should not be considered in the management of patients with stage 2 seminomas unless it's part of the clinical trial. So there's no role for RPLND here. Non-seminomas, clinicians should recommend risk-appropriate multi-agent chemotherapy for patients with non-seminoma with elevated and rising post-orchiectomy serum markers. The study is a multi-variable regression analysis of 453 patients who underwent primary RPLND at Memorial Sloan Kettering with non-seminoma germ cell tumors. They reported that elevated markers at the time of RPLND were associated with substantially elevated risk of relapse with a hazard ratio of 5.6. Clinicians should recommend surveillance for patients with stage 1A non-seminoma, RPLND, or one cycle of BEP are effective and appropriate alternative treatment options for patients who decline surveillance or are at risk of non-compliance. Again, with any disease, when we do surveillance or active surveillance, patient's compliance is the key. So if there's a patient that you think they're not going to follow up, these guys are the one that they should go through prophylactic, I guess, chemo or even RPLND or even radiation. The relapse rate for patients with clinical stage 1 non-seminoma is 10 to 20%, meaning that 80 to 90% of these patients are just cured basically with orchiectomy. Lymphovascular invasion and a presence of embryonal carcinoma in the orchiectomy specimen are the independent risk factors for relapse. Keep that in mind. And of course, shared decision-making is appropriate, so the clinical decision is attuned to the patient's priorities, values, and medical history. This is a Danish study of surveillance of stage 1 non-seminoma germ cell tumors of 513 men with stage 1A non-seminoma. They reported that 15-year disease-specific survival was 99.1%. The 5-year relapse rate of men with stage 1 disease was 24.6%. Stage 1B, non-seminoma germ cell tumor, clinicians should recommend surveillance, RPLND, or 1 or 2 cycles of BEP. These are all equally good. Risk of relapse is roughly about 45 to 50%. It's the same Danish study that I spoke to you about. I just mentioned in previous slides. The relapse rate on surveillance was 43% with presence of lymphovascular invasion. There was a series from Toronto and British Columbia and Oregon that again, their relapse rate was very similar, about 54%. When you have lymphovascular invasion and again, embryonal carcinomas, these are the risk factors for relapse, and those are the ones that you want to be a little bit more aggressive. RPLND or 1 cycle of BEP chemo will reduce the risk of relapse. And it's important, again, as I said, shared decision-making is important to make sure that you are consistent with the patient's value and priorities. And also patients' medical and surgical history may influence the appropriateness of the certain options. For example, if the patient has had prior inguinal surgery for hernia or whatever, this alters the lymphatic drainage. And if you want to do RPLND, it's not going to be as effective. So these are the ones that you want to put through chemotherapy. On the other hand, if the patient has a poor renal function, then there are increased risk of complications if you do chemotherapy, and those are the ones that perhaps RPLND will serve them better. Patient with stage 1 non-seminoma germ cell tumor and any secondary somatic malignancy, also known as teratoma, in the primary tumor at orchiectomy should undergo RPLND. Teratomas have the capacity to differentiate into somatic malignancies and into sarcomas and carcinomas that are less responsive to chemotherapy. And these are the ones that they should primarily have RPLND again. A study, a very limited series of 10 from Memorial showed that patients who received chemo, 7 out of 10 died. And also from Europe, 9 out of 10 patients died if they primarily had only chemotherapy, with median overall survival of 28 months. Again, these are the ones that you want to do RPLND on. Clinicians should recommend RPLND or chemo for patients with stage 2A non-seminoma with normal post-orchiectomy markers S0. They have an excellent prognosis with RPLND or chemo. There's no data to support which one's better over the other one. And if you do RPLND, most men remain to have stage 2A. The relapse rate without any adjuvant chemo is 10% only. And again, if these guys relapse, you can always do the chemotherapy in future. 23 to 40% will become pathologic stage 1, meaning that they're nodal disease and they were overstaged. Some very small number of these patients will be upstage to stage 2B, and they need adjuvant chemo, as relapse rate will become 1% with chemo compared to 50% if they don't receive chemotherapy. Chemotherapy, 90% relapse-free survival. Again, you got to keep in mind there are side effects with chemo: infertility. They can have hearing loss, cardiovascular disease, long-term toxicities are associated with chemo. And as a surgeon, I think these patients will probably just do better with primary RPLND. And again, keep in mind, if they have prior inguinal surgery, you do not want to offer them chemotherapy, because you want to offer them chemotherapy. Surgery is not the best option here because the lymphatic drainage has been changed. In patients with clinical stage 2B, non-seminomas, and normal post-orchiectomy markers, clinicians should recommend risk-appropriate multi-agent chemotherapy, or they may offer RPLND as an alternative to chemotherapy to select patients with clinical stage 2B non-seminoma with normal post-orchiectomy serum markers. Asymptomatic men with unifocal and small lymph nodes, such as less than 3 centimeters in size, again, RPLND may do well for them. Again, these are select patients, and not everyone should go through RPLND. This is a study that it was it's a relatively old study. It's a multi-center study of adjuvant chemotherapy for pathologic stage 2 disease. Over half of men with PN2 disease relapsed if they did not receive adjuvant chemotherapy, and you see the big separation of the curves here. So if they have a stage 2, they do need to get post-chemo RPLND, otherwise they will relapse. Among patients who are candidate for RPLND, it is recommended to consider referring these patients to high-volume centers with experienced surgeons. There was a study in Gold Journal, I think it was out of Vanderbilt, I want to say, and on average, during residency, residents get to assess or see about 4 RPLNDs only, and 50% of graduates get to do about 2 RPLND or less during their training. According to a National Cancer Database study, the median number of annual testicular cancer cases per hospital was only 3. And for patients with metastatic disease, treatment at the high volume hospitals independently has been shown to be associated with better survival, overall survival. And as you see here, the red curve is basically showing the hospitals with lower volume compared to the black line, which is a high volume centers. And you can see the big separation between these, correlating the high volume surgeon and the hospital with better survival. Quickly, minimal invasive surgery in testis cancer. It should be done by experienced surgeon. There's the role of minimal invasive surgery or robotic surgery for RPLND is controversial. There are some retrospective studies on multi-center studies that are more recently coming out. But again, these are very select cases. Some of these testis tumors are wrapped around the IBC or aorta. They need major IBC grafts and reconstruction surgeries, and those are not being done robotically. And so these are what you see in this literature right now. You got to keep in mind those are select cases. But again, RPLND does have a role for management of testis cancer, robotic RPLND. And I just put these 2 most recent robotic RPLNDs that we've done. You are able to clean the intra-aortal cable, para-aortic lymph nodes. And on the right side, you can see the preservation of sympathetic fibers. And this is a patient, they were both post-chemo. On the right, this patient had about 8 centimeter para-aortic mass that ended up being a teratoma. So for primary RPLND, you got to know your boundaries. The cephalad boundary would be the renal hilar vessels all the way down to where the ureters are crossing the iliacs inferiorly. The principles should apply to both open or laparoscopic or robotic. and you have to clean all the lymph nodes. You got to clip all the lumbars and take them out. And you have to be able to roll the IVC and the aorta back and forth to make sure you clean everything. If you're not able to do this robotically or laparoscopically, it has to be done with an expert who specializes in these, either open or robotic. Again, full bilateral template lymphadenectomy should be performed. I'm going to go through this quickly for the sake of time. You can offer modified templates clinically in patients with a negative lymph nodes, which I will go through in the next slide. Right-sided templates, you may omit para-aortic lymph nodes below the inferior mesenteric artery, avoiding dissection above para-aortic lymph nodes above the inferior mesenteric artery is controversial. On the left side, you can omit paracable or retrocable or precable lymph nodes. And again, if during dissection, if you have suspicious lymph nodes that you see, then you got to convert to full bilateral template dissection. After primary RPLND, clinicians should recommend surveillance or adjuvant chemo in patients with non-seminoma germ cell tumor who have pathologic stage 2 disease that is not pure teratoma. A study from Williams and colleagues in 1987. Again, these are the studies that we keep referring to because they're landmark studies and they set the ground rules for the way we treat these patients with testis cancer. Adjuvant chemo versus observation for pathologic stage 2 disease showed that significant reduction in relapse and no difference in overall survival. For patients with N1 and pathologic N1 to N3, pure teratoma surveillance is preferred. And for patients with N2, N3, multi-agent cisplatin-based chemotherapy is preferred as the recurrence rate were lower from 50% to 6% with chemotherapy. Surveillance for stage 1. The safety of surveillance for stage 1 seminoma is well established. I mean, the disease-specific survival is 100%. Relapse is mostly identified by CT and serum markers. So when you follow these patients, if they're going to relapse, you will see them on the tumor marker mostly and CAT scans. If they're going to have a relapse, the median, it happens median time of 14 months with 92% identified during the first 3 years of surveillance. So if you clear the first 3 years, most likely these patients will not have recurrence. Relapse rates range from 13 to 19 months, which is curable with salvage therapy regardless. This is a surveillance schedule right out of the NCCN for after orchiectomy for seminomas. You see them every 3 to 6 months in the first year for examination and tumor markers, and you get imaging at 3 months, 6 months, and 12 months. Second year, you do exam and imaging every 6 months, and the same thing with the third year, and then annually after that. And you can probably stop after 5th year. For non-seminoma, relapse is seen in 19% with median time to relapse in 4 to 8 months, so a little bit faster than seminoma. More than 95% of patients on surveillance will experience a recurrence, and will do so during the first 2 years. So again, you want to keep a close eye on these patients for the first 5 years, and if they relapse, you can proceed with treatment. If they have lymphovascular invasion, obviously their relapse rate would be much higher than those who don't have relapse, who do not have lymphovascular invasion on orchiectomy specimen. And again, CT and tumor markers are adequate to monitor these patients. And again, this is out of NCCN, the surveillance schedule for active surveillance after orchiectomy, a little bit more intense than seminomas, but after basically 5 years, you can, if they have shown no recurrence, you can dismiss these patients. If they relapse on surveillance, then you restage them again. You get markers, TNM and S status, you get updated the CT imaging, and appropriately you treat them. Rate of relapse after 5 years in patients with stage 1 germ cell tumor is less than 1%. So after 5 years, you can dismiss these patients. So some notes on survivorship quickly. Patients with germ cell tumor should be monitored for signs and symptoms of hypogonadism. After orchiectomy alone, that's like 10%, okay? If they're treated with both radiotherapy and chemotherapy, then hypogonadism is about 35%. Study by Fossa and colleagues in 2007 showed that basically orchiectomy alone increased the risk of hypogonadism by 1.8 times, radiotherapy 3.6 times, and chemotherapy 4.4 times. And if you combine those radiotherapy and chemotherapy, obviously it's much more. Those treated with radiotherapy and chemo should be advised on the elevated risk of cardiovascular disease. This is a international study that I just mentioned in the previous slide, reporting the risk of cardiovascular mortality was increased 70% among testis cancer survivors treated with radiotherapy when younger than 35 years, but did not show any increased risk if they were 35 years or older. And this was increased to 44% for survivors who had been treated with chemo regardless of age at the time of treatment. Cardiovascular mortality was also doubled among those, again, who were treated with radiotherapy and chemotherapy. Patient with a history of germ cell tumor who were treated has also, they need to be closely followed by the primary care doctor. There's a development of risk of getting a second cancer is high in some of these patients. And there's a study, a multi-center study on 40,000 patients with testis cancer who were treated. Basically, relative risk of secondary malignancy after radiotherapy in long term is about 2 times with 95 with a confidence interval of 1.9 to 2.2, and after chemotherapy was almost about the same relative risk of 1.8. Again, these patients need to be followed by the primary care doctor long term, as these guys have a higher risk of getting secondary malignancies. Lastly, future directions. I mean, there are exciting research happening right now in testis cancer, especially these circulating tumor markers. These tumor markers are currently, there are a couple of trials are running. They are basically, I know you had a talk recently that they went over through these, they went over these markers. These guys, at some point, they're going to be driving the show here. Specifically, I think the last one, MIR37, this tumor marker is not elevated in patients with teratoma. And I think over the next 2-3 years, they'll hopefully become a routine in institutions who treat these patients with testis cancer. There were a lot of information there. Again, I don't think there is any easy way of learning testis cancer. I think it's repetition. I think the guidelines, they have some points for you guys to just go through and learn. It's the surveillance, the schedule. I think it's good for you guys to have on your iPhones or your tablets. Basically, if you're doing surveillance in your clinic, you can just easily refer to. And again, I personally follow these patients with medical oncologists myself. It's a multidisciplinary approach. And it's definitely needed for these patients to be followed very closely, regardless of if they're on surveillance or they have had treatments for chemo or radiation. If you have any questions or if you need these slides to be emailed to you, please feel free to email me. And thank you for inviting me to give this talk.
Yeah, no, thank you so much. That was such an amazing review. It's going to be very high yield for any residents studying for the in-service, fellows for their boards. So thank you very much. We do have some questions. If you don't mind, we'll try to get as many in before our next talk.
Sure.
One question I had, you had discussed one of your patients, I think he was a 29-year-old, 1.8.
Yes.
I wanted to see, what scenarios what other scenarios do you consider testes biopsies, partial, like testes sparing surgery?
Well, very rarely. I mean, and very rarely. This is like, I mean, I end up doing this maybe like once or twice a year max. I mean, first of all, like most of the testis tumors that you see, it will be radical inguinal orchiectomy. This was specifically, this patient had a complex cystic lesion at the lower aspect of a testicle. Very, this patient was not happy about, just losing a testicle. And I just had a feeling that this is not a testis tumor.
Mm-hmm.
So again, if a patient is very resistant and you feel like, doing an orchiectomy is going to psychologically really affect them, and you have enough reason to give it a chance, and it's less than 2 centimeters based on, what we've seen in the literature, it is reasonable to try. Again, it has to be done appropriately. You got to have a good GU pathologist, and you got to have the patient regardless mentally ready that you might end up doing a inguinal radical orchiectomy.
Sure.
But and you got to, you can't forget about doing biopsies around the normal tubules when you're doing testis sparing surgery to make sure there's no other cancer cells.
Mm-hmm. Okay. Ethan Fram had a question.
Yes.
He was asking in regards to one of the studies that you showed, what's the role of checking LDH post-orchiectomy? It seems like a lot of the studies just focused on AFP and beta-HCG.
It's non-specific. I mean, I think it just, historically, we use it just to see if there's any bulky disease in the retroperitoneum. Routinely, we send all 3 of them, but most of our treatment is driven by AFP and HCG. But we send it just to have a kind of as a group, just to have an idea what's going on in terms of bulkiness of a disease. But if there's no retroperitoneal lymphadenopathy on the scan, that LDH is going to be normal.
Sure. And I always find this interesting, with the United States Preventive Service Task Force recommendation of kind of the grade D of testicular self-exams. How do you as a clinician kind of counsel your patients with regards to self-examination? And how do you feel about that proposed guideline?
Well, I mean, self-testicular examination, I mean, unfortunately, it's one of the pains in uro-oncology practice. I guess we get a lot of these testicular pains. A lot of the referring doctors think that, if a patient has a testicular pain, send them to a urologist, it's a testis cancer. So you get to see a lot of these patients, unfortunately. And it's very frustrating for the patient and the physician because they come to see you, they want something to be done, and there's really nothing to do. And I always counsel them at least do a testicular exam before I dismiss them. And I tell them to just do self-testicular exam. If you feel anything different, you call me, you come back. I do think it's easy to do, and it should be basically recommended. I mean, I don't think it should be dismissed, and it's a very important part of the screening for young men to make sure that if you have testis cancer, you can get them at an earlier stage.
Okay. Well, in the sake of time, just thank you so much again, Dr. Mehrazin, for.
You look good. Thank you. I hope I didn't take your time. And
no, this was amazing. It's going to be a great resource for us. I'm telling you, when we study for those boards,
yes.
Fellows too in service. But thank you again.